patients may not know if they've received these important tests. So what key questions should they ask their physician about testing?
Well, I think it's important that the patients feel empowered to understand sort of where the field is and what key questions you would ask a physician hematologist who's taking care of you. So, I think all patients should be aware of their diagnosis, the name of the diagnosis, the subtype, but also, do they have any of the key driver mutations, the JAK2 mutation, the calreticulin mutation, the MPL mutation? That's usually done off of a bone marrow biopsy sample, but can be done off peripheral blood. And they may not always know that it's done. So I think having a discussion with the physician to understand, there are criteria that exist called the World Health Organization criteria that are updated frequently and should set a standard throughout the world of how you diagnose and establish these diagnoses. So I think it's important for physicians to be able to convey to the patients with confidence, we follow these criteria and you have these criteria and we've done this testing that shows that you have these mutations and not just regurgitate what they found, but help them understand and navigate what that means, which, again, I will point out that sometimes we don't know, but I think it's important for physicians to convey sometimes that some of the findings that they may see, for example, patients look on portals these days and they can look at their labs and stuff like that. We don't always have a terrific answer or an informed answer for everything that we get back. And that we will potentially in 10 years from now, but sometimes at the moment we don't. But I think a discussion about the meaning of the labs that are obtained is probably good for the patient to understand what's being done.
Absolutely. It sounds like each person's situation is unique and should be considered before making any treatment choices. Can you talk about how the results of these tests may affect prognosis and treatment?
So we do use, we have risk stratification systems that we use for essential thrombocythemia, polycythemia vera, and myelofibrosis. I'll talk about myelofibrosis because that's probably a little bit more of a complex and sophisticated model that's also changing, and we update it frequently. And these models are imperfect, so I always warn patients to not put all of their their money in one basket when we talk about risk stratification. They broadly help us understand where a patient is in their disease course. So, for example, in myelofibrosis, historically, the DIPS, the Dynamic International Prognostic Scoring System, was used, which considered 5 clinical variables that have been shown to be independently prognostic. So, age over 65, the presence of blasts or circulating immature cells in the peripheral blood, anemia, hemoglobin less than 10, symptoms, fevers, night sweats, weight loss, or high white count over 25,000. You add those points up, and patients can do this online. There are calculators that you can calculate your DIP score, and you'll see that there are 4 different risk groups that range from low risk to high risk, and they are associated with median survivals. We now know that mutations influence those, have influence on prognosis. So there are a group of high molecular risk mutations like ASXL1, SRSF2, IDH1 and 2. So there are mutations that also have prognostic significance, and we incorporate them into the decision making. And essentially, and this is where I think patients have to be very careful, physicians have to be very careful in conveying this. With these risk models, whether they are clinical variable risk models or these integrated molecular risk models, each category is associated with a median survival that's based on retrospective studies, but that doesn't tell the patient specifically what they should expect in terms of survival. And I always fear that patients, when they look at these things, or even physicians when they convey them, that they may inadvertently misrepresent or convey what those really mean. I think the purpose of those risk stratification tools is really to help guide a risk-adapted treatment approach that's reasonable and is weighted for benefit to risk of the disease. So, for example, if you have advanced disease with a high risk score of intermediate 2 or higher, bone marrow transplant in certain patients may be a warranted therapy to consider. So they really help inform treatment.